So hello, welcome. Welcome to this session, which is one where I love that this is a small room, an intimate space, and a nice tight group, so that we can really just have a conversation. I'm Kourtney Santucci, so I'm a pediatrician for children who have medical complexity, and I work at Children's Hospital Colorado. Have for a little over 10 years now. And I want to say thank you to the BDSRA for inviting uh, us to give this presentation about the role of palliative care in the care of children who have Batten disease. And so I'm here to introduce Dr. Heather Brown, who is a doctor of palliative medicine from the Kennedy Krieger Institute and a wonderful parent representative who's going to share her experiences, Karen Kahn. So I'll hand it over to Dr. Brown.
Thank you. And you guys can all hear us okay? Okay, perfect. Well, good afternoon. Thank you all for being here. It's been so lovely to meet all of you and really get a chance to learn your stories throughout this conference weekend. Um, my name is Heather Brown. I'm a pediatric palliative care doctor. I work at Johns Hopkins and Kennedy Krieger Institute in Baltimore. And I do a combination of roles within palliative care. At Johns Hopkins, I see patients in the hospital through the inpatient consult service. And those are the patients with many different diagnoses who are sick and spending time in the hospital. But I also spend most of my time actually in outpatient clinics at Kennedy Krieger Institute, where I see kids with really complex chronic medical conditions who are at home but have a lot of needs. And I also see consults in the rehab hospital at Kennedy Krieger. Many of the people I meet don't know what palliative care is and are not really sure what our role is for kids with medical complexity and chronic medical illnesses. So, today during this talk, we will learn a little bit about palliative care. We'll debunk some of the stigmas associated with palliative care, and we'll hear from a family. So, what is palliative care? Palliative care is specialized medical care for people with serious health conditions. Palliative care providers treat patients of all ages and at any stage of illness. We treat patients with chronic, curable, or life limiting conditions. And we help manage symptoms and stress of serious illnesses. Our goal is to improve quality of life for both our patients and their families. We strive to prevent and relieve suffering. Um, and we understand that patients with serious health conditions often have really complicated courses and many different specialists involved in their care. And that adds more stress, an extra layer of stress for the patient and the family as they're going through this journey. So we can help by communicating with the interdisciplinary team and helping to coordinate the care associated with their medical condition in order to help ease some of that stress and make sure that all treatment decisions are in line with your goals for your child. So, providing care and support to our patients and families requires regular, open communication among the patient, the family, and the entire healthcare team involved in the patient's care in order to help families navigate their medical journeys. How does palliative care provide support? So, we aim to relieve suffering by treating both physical and psychological symptoms. We help families navigate difficult, often complex medical decisions and treatment options. And we do this by getting to know your family and getting to know what's important to you so that ultimately we can make decisions that are in line with your goals and your values for your child and for your family. We stay in close communication with all of the medical providers caring for your child in order to coordinate care in a way that best meets your needs for your child and for your family. And our goal is also to support your child and family in any way we can throughout the illness. So palliative care is a specialty that focuses on quality of life. We provide pain and symptom management to alleviate the distressing discomfort associated with the disease. We provide emotional and spiritual support and assist with family coping. We help with family centered, goal directed decision making. as well as advanced care planning to ensure that decisions are made in alignment with the family's values. Palliative care emphasizes interdisciplinary communication and care coordination, and the goal is to optimize quality of life for the patient and the entire family unit. And as we said, palliative care can be beneficial at any stage of illness and can complement life prolonging treatments. The ultimate goal of palliative care is to improve quality of life, but this is a big umbrella term. And under this umbrella, there's many different aspects of care, including symptom management, psychosocial support, exploring goals of care, and advanced care planning. The goal is to live as well as possible for as long as possible in the face of serious illness. And our big job is working with families. So we spend time getting to know the patient and spending time with the family. We consider each family's unique situation and we identify ways to make their journeys a little easier. We strive to determine a treatment approach that's aligned with both the patient's and family's goals and addresses the comprehensive needs of the patient. To do this, we offer symptom management, communication, family support, guidance, resources, and connections. When your palliative care provider is getting to know your family and your values, they may ask questions such as, what are your guiding principles? What are your hopes? What are your fears? What brings you and your child joy and meaning? And we need to remember that these can change over time, as values and goals also change over time. So it's important to continue to reassess and continue this conversation at each visit that you have with your palliative care doctor. Families can have different goals, and I often hear many different goals and hopes from my families. Some examples of these goals are to improve mobility and independence, to maximize comfort and happiness and reduce pain and suffering, to spend as much time together as a family, or to stay at home and stay out of the hospital as much as possible. It could be to protect your child from invasive interventions and procedures. Your palliative care doctor will ask questions to understand your experience as you navigate this journey. So they might ask, what has it been like to be on this journey with your child? How do you define quality of life? Quality of life for your child and for your family. How do you approach decision making? How do you make decisions as a parent or as a family? And what factors do you prioritize when you make decisions? What does a good day versus a bad day look like at home? And how often are those happening? And when you face difficult times, what helps you get through them? Family, faith, community. What do you do to cope during difficult times? And what do you do to take care of yourself? Yeah, that was a lot of information. We can pause for some questions, and then at the end, we're going to have more of a Q&A. Any questions right now? Yes.
I know this would be better for Julian, but just that specific content, like what are you talking there about complex decisions? Like what are some of those complex decisions can go through with that is?
That's a really good question. So there's several decisions, or many decisions actually, little decisions and big decisions. So some of that is symptom management. There's medications that can cause side effects and often do cause side effects. So balancing, the need to intervene, especially with behavioral concerns. There's often a lot of side effects from psychiatric medications that can be really detrimental or negative in a patient's or family's life. So balancing those side effects with the need to modify those behaviors or control some of those symptoms. Um, There's decision-making points that come up related to surgical interventions, so needing things like a feeding tube or additional respiratory support, potentially a decision to have a surgical airway or respiratory support. Um, Hospitalizations, also when it's important for a family to have a hospitalization and get all the answers and care that they need, or when it's important to be at home and enjoying that quality time at home together with family. um, and I think that actually goes hand in hand with really bigger picture goals. So when is it time to say it's time to prioritize our quality of life and really enjoy the time that we have together, versus having interventions that may not be helpful or may be more harmful than helpful. Did that answer your question? Any answers from the group?
Oh, I was actually, so my name is Karen, and my daughters now, Amelia and Mackenzie, are 14. They were diagnosed at 7. And so the best thing that my sister did for me, who's in the medical field when the girls were diagnosed, week 1 was she found us a grief counselor and she connected us with palliative care. And I was, the myth of just devastated when she even suggested that we be followed by palliative care. And within the first month, we had our first appointment. And I really didn't understand why back then, but I do now. And it was really just establishing a baseline of the doctor getting to know our girls as they were then, getting to know our family, and following us so that when these decisions came along, it was much easier to make. And I can speak to everything that Dr. Brown just said is that, you know, medications, especially for my one daughter, Amelia, has always been a challenge. And you start with saying, well, I don't want to medicate my child. But when you say that, quality of life and happiness is the most important thing, there becomes a time where it's obvious that that needs to happen. And then it's balancing those medications, obviously, with the side effects. And I still remember we also were given a social worker in Arizona back then, which I couldn't believe. Why do I need a social worker as well? Um, and I remember her saying to me, because we were talking about, Amelia's episodes, happening for hours and her aggression and me not wanting to give, a rescue med because then I'm drugging her. But then it was, well, who's winning there? I'm upset, she's screaming. So really it was opening my eyes to, her quality of life was, getting that medicine to make her calm because she was agitated. And, as far as G tubes go, we had that conversation for a long time. And, when the girls were diagnosed, I said, I would never get them a G tube and just extend their life. Both my girls have G tubes and have for 2 years now. And, Mackenzie surprised me. It was she stopped eating, just a motor planning issue. She eats again now. But and Amelia, I was scared. Even though it had come up multiple times, it was because it was such a challenge to get those rescue meds in her PRNs to make her happy. I couldn't get her to take the medicine. So, but then the decision of having a G tube just for medicine just was like, I can't believe I'm going to do that. But then it seemed so easy after we did it for Mackenzie that we ended up a month later getting Amelia a G tube. And therefore, her medications are consistent. We can get everything in her. It's on schedule on time. So that in itself, made it easier to manage everything. I've been through the whole thing now with 7 years, with Amelia and both girls, but especially Amelia because she got RSV, 18 months ago and was on a ventilator for 3 weeks. And I wasn't prepared for that. I mean, I'd been prepared. We've been talking about this whole time, but at the same time, when you're in that moment, it's you can't completely prepare, but having had those conversations ahead of time makes it that much easier. And I think, like they said, you're constantly evaluating and changing. So even what you said when the girls, for in my case, when the girls were diagnosed at 7 versus what I decided to do at 12 and what I've learned along the way, and even in that moment, you can always change. But I feel like for years you've been kind of in the back of your mind processing some of these scenarios.
Agree. So as a palliative care doctor, how often do you visit the families?
That's a really good question.
Because that's called
Mm.
after COVID. Everything is go after COVID. Because in the last 4 years, I saw my palliative care doctor only on the first visit. Then we go to the clinic, to her clinic, which is like always we have interruptions because she is a She's one that is on research. She's the one that is a professor in the university. I don't think that I get that like one-on-one time that I need with her or to explain things. So I mean, like maybe this is for later on, but like in the basis, how many times do I have to see her like coming to my house, for example, or her nurse, or her NP, whoever?
That's a really good question. So you have a home-based palliative care team. Is that
Yes.
correct? Okay. And that's we will get into actually, I'm going to pause. Do you mind if I forget to answer that? Remind me, but I'm going to pause and get back to some of these myths. But I do want to talk about different care models and different I think you were asking mostly about the frequency of follow-ups. So we'll go into that as well. But please remind me if I don't get to it.
Yeah.
Thank you. Okay. So I'm just going to pause the questions for now. We'll go back into the Q&A at the end. But we're going to go through some myths and we'll try to debunk some of these stigmas associated with palliative care. So myth number 1, palliative care is for people who are at the end of their lives. Actually, palliative care can and should be integrated early in the disease process while disease modifying treatments are being offered. And that's to maximize quality of life and ease symptoms and suffering throughout the entire journey. This is the integrated care continuum with palliative care. So as you can see, palliative care and supportive care can begin very early at the time throughout the disease process, even at the time of diagnosis. And we can collaborate with the patient's care team as they're undergoing disease-directed therapies. And as the condition progresses and the disease-specific treatments become more limited, the role of palliative care may evolve over time. Goals might shift to a more comfort-focused approach in order to optimize quality of life. And then even after a child dies, the palliative care team can continue to support the family in their bereavement. Myth number 2, palliative care is hospice. As you can see in this diagram, palliative care is a big care approach, and hospice is only a small portion of palliative care, and that's the portion that occurs at the end of life. Patients can receive palliative care throughout their journey, even starting as early as time of diagnosis. And at that point, they could be doing really well, not in the hospital very much, pretty healthy. And then they only will receive hospice care when their life expectancy is less than 6 months. So that's the end of life component of palliative care. Now, this is a lot of words, but we're going to talk about the differences between palliative care, hospice, and then talk about concurrent care. So palliative care is a specialty that serves as an added layer of support. It's offered to a child and family with a diagnosis of a serious illness with uncertain outcome. And it may be offered at diagnosis or at any stage of the illness. And it's concerned with the whole child and the whole family, including physical, emotional, and spiritual needs. And it might be delivered in different settings like the hospital, outpatient clinics, or in the home by a community palliative care team. Hospice is supportive care without curative intent, and that's offered when quality of life and not quantity of life becomes the number one priority. It's offered when the disease is no longer responding to medical treatments or when there's no further medical interventions to treat the underlying illness. And it's offered when life expectancy is less than 6 months if the disease were to follow its natural progression. The focus of hospice really is the same as palliative care. It's management of physical and psychosocial symptoms and suffering. And then this piece, concurrent care. So that's for children enrolled in hospice who receive Medicaid, and they're eligible for concurrent care. That allows them to be enrolled in hospice while still receiving ongoing or new treatments that are disease directed. So they can be getting full aggressive interventions as they were doing, and then they can also get hospice in addition. Hospice is often based out of the home. Rarely there's inpatient facilities that can offer hospice, not very many for kids. Most of hospice care is done in the home. Myth number 3, palliative care is only used to treat pain with morphine. Pain is one of many reasons for a palliative care referral, and there are many options to treat pain, which includes medications, both opioids like morphine, but there's also other classes of medications to treat pain. And then we have non-medication options to treat pain as well: massage, acupuncture, aromatherapy, even things like PT and OT, physical therapy and occupational therapy, can have pain approaches as well. And there's also other symptoms a patient could be experiencing that palliative care can alleviate. And those include nausea, vomiting, diarrhea, constipation, loss of appetite, trouble sleeping, fatigue, anxiety, depression, itching, irritability, restlessness, behavioral concerns, spiritual distress, and caregiver stress. Myth number 4, palliative care sounds like it would be too expensive. Actually, palliative care is a medical specialty just like neurology, gastroenterology, and cardiology. And therefore, in the community, insurance covers palliative care visits the same way that it would cover other specialty visits. And if you're concerned, you can contact your insurance company before scheduling a visit in the community. Myth number 5, when we work with palliative care, we will no longer see our other physicians. Palliative care doctors work with your other providers to assist in the management of symptoms and quality of life. We often have lots of conversations either by phone or email to discuss shared patients. And many times I'll even do family meetings or team meetings through Zoom or in person to really talk through care plans to make sure that we're doing what's best for our child and for the entire family. So palliative care doctors do not replace the other providers. They work with the other providers. The palliative care consult team will work with the primary team and the primary care physicians, and then the other subspecialists involved to come up with a treatment plan that aligns with the goals for your child and for your family. And one of the best parts of this work that I love the most is working with families. These are the people who are with my patients or our patients day in and day out. They know the patient better than any medical provider involved in their care. And it's really an inspiration to see their dedication and devotion as they provide excellent care 24 hours a day, 7 days a week. I'm so honored that I get to do this work and I get to work with amazing caregivers every day, just like you. And I know you already heard a little bit from Karen, but it's a pleasure for me to introduce Karen as she shares her story caring for her kids. Thank you.
Yeah, so I share a little. So Amelia and Mackenzie, they're 14 now. And when we started, like I said, I really didn't understand why we need to see palliative care. And it's just been ever since then, just a huge part of our journey. In the beginning, it was just going and talking to the doctors and really easygoing and just, letting them meet the girls and meet us and ask us some, simple questions. And you almost looking back don't even realize how it grew because it became this partnership with them, that, a doctor that's constantly just kind of checking in and seeing how everything is going. And I think that the amazing thing is, the Batten parents, we all become so involved in the daily life and we kind of lose track of the bigger picture and don't really notice the changes or don't really know the other options to consider to really bring the happiness, to our kids. So all of a sudden, if they see you once a month, once every 6 months, they're more attuned to some of those changes and the other opportunities that are out there, to help your family. And it does come down to, every decision we make for our girls, I always have that in the back of my mind of, what, really the best quality of life for the girls, and those opportunities. And even, when they get further advanced and along and you're in the hospital, I mean, you have that connection with the doctor who, and there's this trust of, I think the best option is for us, to go home now. And I think we can manage from here, with our child. Um, it has been just a huge benefit to us. And, 2 years ago, we moved from Phoenix to North Carolina. And it was our team of doctors at Phoenix Children's Hospital who had followed us for 5 years that found our new doctors at UNC because we had that connection. They knew our family, they knew our girls. And the most important thing for us was to have that continuation of palliative care on our journey.
So just a small comment from me, from my angle. So I'm kind of coming from the perspective of a primary care doctor who pretty exclusively takes care of kiddos who have complex medical conditions. But I think that any primary care doctor taking care of any child would welcome partnership with a palliative care provider for a patient whose condition is complex and chronic. It really is. It's a team, it's just another member of the medical team. Um, I've definitely heard from families that they're leery to engage with palliative medicine because they feel like that would then replace some of their other medical team or even their PCP relationship. And as Dr. Brown said, it really doesn't. It's just additive to the resources available to family. I always appreciate the fact that for most home-based palliative care teams, the situation is that there is a person who can actually go out to the home. They can go into that house, and um, I I think that's huge, right? It's a huge benefit. And the immediacy to be able to respond to symptom management needs by a home palliative service also exceeds, I think, what generally we can do through a medical home, like through the PCP's office. So it's a welcome partnership, and I think really only adds value for families. So on that note, and maybe giving you guys a little time to digest all that you've just heard from Heather and from Karen, are there questions or things that you would want to ask or discuss? Because really, we intend this to be no holds barred, right? And very conversational, so that you leave feeling like you really understand what palliative care could offer for your family. And
And I can get back to that question that I tabled.
for sure.
So to get back to the question about frequency of home-based palliative care follow-ups, so that's a really good question. I think the reason it's a little bit complicated is because there's different models of palliative care and different types of palliative care offered in different communities. So where I practice, I do outpatient palliative care and inpatient palliative care, mostly outpatient. And there's some home-based palliative care options in our area that are affiliated with the hospice agency. So those are kids who are getting palliative care, not hospice services, but it's run through the hospice, like the overall hospice name. And that when they're on those programs, I believe they do every 6-week follow-ups with the physician, the outpatient palliative care physician. And that might be different based on needs. In our outpatient clinic where I practice at Kennedy Krieger, um, with the Batten clinic, we see patients in our Batten Center of Excellence clinic every 6 months or so, and I'm available and present during all of those multidisciplinary clinic visits. So I will see every patient that comes in for that multi-D visit, which is a really long, full day with lots of different providers. So I'm only one portion of that multi-D day. If I do notice that that patient or the family has many palliative care needs, I'll schedule them separately and do more frequent follow-ups. 6 months is a long time, I think, to go between palliative care visits, especially when there's a lot of different clinical changes happening or different needs that are not met. I think it's important to continue to reassess, and if things are totally fine and there's no needs, then we can go a while between visits, but usually our patients are pretty complex, and 6 months feels like a very long time for me to go between those visits. Sometimes I'll see my patients as frequently as once or twice a month. Sometimes I'll wait longer periods of time, depending on kind of what's going on in their lives. So with the home-based palliative care team, I think it would be important to make sure they understand what your needs are and what the questions are, what hasn't been met, so that they know what frequency of follow-up to do. Have they given you any recommended intervals? And actually, can we get a? I'm going to pause you for a second. Think we have a video recording, so we just have to get you on the microphone.
And I'm making you.
Uh, I live in Michigan, and where we decided to choose the palliative care, going with that, we decided to go with a home palliative care slash hospice. I know the meaning and everything, so I decided to go with them because I thought they will come at home, assess us at home, and it will be easier for our daughter than taking her and going to the hospital. So we met with the team, and it was just before COVID. The doctor came at home, and she had a nurse too. So they both came at home, they did the assessment, they talked to us and everything. Then the COVID happened, and they weren't offered anymore like the home visit. So they are like a home care team, but they're not doing anymore the home care team because we are not cleared from COVID, I think. Everything comes around and everything goes but it's still, we don't have the clearance to go around and see the patients. So we see her at least like twice a year, but I have to take my daughter in there. And in one of the days that we went in there, she had like a call from one of her students, doctor or whatever resident. I'm sorry, my English is very bad today. Um, she got a call from a resident that told her it was like an emergency, and it wasn't an emergency. So she took her time and left the room for an hour, where I have a kid that everybody remembers from the last time that I was around, that she was like very aggressive, and like she was like misbehaving and everything. So that was my thing, is like, do I still have to continue with the palliative care with this if if they don't come at home? Or do I have like to look around and check for a new team?
That sounds really frustrating, and I'm sorry that you are dealing with that. Um, it's hard for me to say because I don't entirely know what's offered in your area and what the structure of that team is like. Um, I'm I always tell my families my goal is to
The
be
the
helpful.
one that we have right now, the our doctor, she's a palliative hospice doctor, and she took care of two other kids with Batten's disease before she got my daughter as a patient. We chose her only from that she had experience. She's an amazing doctor. She is an amazing doctor. But the thing is, frustration is like, you give them call and you have to wait 24 hours to 48 hours business hours for them to give you a call back, where I understand like palliative hospice care, they're supposed to give you answers earlier than that. So, but I think in your area, I totally understand, because like you have a team of you have the Batten disease clinic in your cities, in your state, which is the great thing ever that is offered to us. But for us, we don't have a clinic in Michigan. We have one in Ohio, but not in Michigan.
Right.
So
Yeah, and you know, Batten disease or not, I always tell my families the goal of palliative care is to reduce stress and make things easier. So if the service is actually making things more stressful or more complicated, then that's not serving the right role. It's not helping. So I would say if you feel like it's helpful, stick with it. If it doesn't feel like it's helpful, then it might be worth it to try to find another team, maybe with a different structure. So while I am clinic based, I do probably 50% of my visits on Zoom because a lot of my patients are really medically complex or medically fragile, and coming into a clinic is too difficult. So a lot of my visits are on Zoom. Then I get to see the whole family. I get to see the pets and the living situation, and it's actually really nice, even though Zoom is not always the most ideal. But there might be an option like that might give you more frequency of follow-ups and serve your needs a little bit better, and not make you come to a clinic and wait for a long time to be seen.
And I think kind of going into this session, one thing that we anticipated was that in the audience, folks would be living in lots of different places. And, the resources or the palliative care services that are available to you will vary by your location. Um, it- I like that Dr. Brown sort of divided out kind of clinic based versus in-home based as a basic dichotomy, because I think that is pretty universal. But really, my advice would be to maybe use if you don't yet have a palliative care team or know what the resources are in your area, to maybe speak with your neurology provider or your PCP, because they have probably had other patients who have used palliative care team in your area and can sort of point you in the right direction and maybe talk through with you which is the best team for what you mostly need. In the Denver metro, we have a few different options, from hospital based, mostly via Zoom, to more in home service. And I think it's just a different right fit for different families. Yeah.
Is is there any palliative care that can go outside of the state? Like I live in North Dakota and I have the same issues as her. We palliative care is non-existent in North Dakota. They basically told me if you want palliative care, we can help you take your daughter fishing. She doesn't want to go fishing. I'm sorry. So we actually get ours at Mayo Clinic in Rochester, Minnesota. And all they do every single time we have our Zoom meeting, all they ever do is say, "Hey, do you want to put her on a DNR yet?" That's that's all our communication is. So they don't help with anything with pain or moods or anything. Like I have to keep finding different doctors, asking different doctors to refer me to different doctors. And my big problem is my daughter's regular physician is a special needs physician, and so she is very she knows her stuff, but she has no idea about Batten disease. This is her first case with Batten disease, and but she still thinks that she knows everything. Like, like she has done a lot of research. I give her credit there, but she hasn't really like gone above and beyond, like she doesn't understand the complications. Like I'm typically going on the Facebook page and, "Hey, can anybody tell me this so I can tell my doctor this?" And that's how we get everything. Like everything has been, "Hey, other people say that they have their kid on this medication, can we get this medication and try it?" And I don't feel comfortable doing that, because it's like, just because it works for somebody else's kid doesn't mean it's going to work for mine. I want a doctor that knows what's going to work. You know what I mean?
Yeah. And i- it is really tough when you're living in a place where there just really isn't a
Yeah.
palliative care service that can come out to the home. In those scenarios, I think we have to just paste together a good plan as best we can. I will say, it does seem to me that one of the goals of the centers of excellence starting up from the BDSRA is to create a web of locations across the US that gives any family living in any location really at least a nearest center
Right.
that could be that hub to support your local doctor, so your local PCP, if you have a separate local neurologist, local psychiatrist, etc.
Yep.
That's also meant to be partnership relationships, and so maybe that's one way forward, is to connect. Might be our center at Denver, actually, since you're in North Dakota.
Yeah,
um,
we've
but
we've
to
been going to Rochester, which
Oh
Mayo
yeah,
Clinic is
yeah,
supposed to be the
yeah,
the best place ever, but
yeah.
and our her doctors have dealt with Batten disease, but not so much with the one that my daughter has. Like my daughter has CLN2, and what they do with them is they bring them in to start the treatment and then kick them out. Like we were there for a couple months, and they were like, "You got to find a new doctor. We don't have room for this. We don't have time for this. Like goodbye," So we keep kind of getting pushed around. It's like it would be nice if there was something like you guys do Zoom visits and stuff. Like I could get a referral. Is there any facilities out there that would just do Zoom visits for people who live in these states? Like she has North Dakota Medicaid, so Medicaid is very particular about what they'll do, but for the most part I can usually tell her doctor, like, we need this, you need to sign it over, and she will. But finding the facility, it's all on me.
Yeah. Huge challenges. I don't know how to solve them. Sitting up here. Did you have a comment? Too? Yeah.
I will say the big issue with that is licensing. So palliative care doctors can only practice in the state that they're licensed in. The one probably only perk of the pandemic was that was lifted a little bit, so the state restrictions were not quite as strict. But yeah, so if you can't do a Zoom visit with a physician in another state if they're not licensed in the state that you're in. So that's the really tricky thing. I, I w- I would I would keep asking around. There's almost guaranteed adult palliative care doctors. They're they're going to be slightly different in their training and experience, and probably are not going to be as familiar with Batten disease or the specific symptoms and needs, but may still be an extra layer of support. So that's one thing that you can look into. And then the other thing that I like to tell all of the patients and families I take care of, have you looked into Courageous Parents Network? Have you heard of that? It's a resource. Actually, they have a talk happening right now in the next room over. um, you could actually. That's the website. Well, not all of it, but it is an amazing resource. It's courageousparentsnetwork.org. It's an amazing resource for not Batten disease specifically, but really just children with medical complexity, with really chronic medical illnesses and special needs. And there's a lot of educational tools, some support groups on there. But there's, even when you're talking about these decision making points where a palliative care doctor would be super helpful, they have decision making tools on their website, talking through kind of the pros and cons, family experience when this decision is made versus this decision is not made. It's really good. Some of them even have like treatment journeys, like you can walk through a whole like journey map of like, if you were to make this decision, what are the things you have to think about, what things might change in your life, in your child's life. It's a really great resource. So I would encourage you to look into that. Yeah, it has an app. It has a website and it has an app. So that's a good resource. Not the same as a palliative care team, but it's there's a lot of, yeah, there's a lot.
Content vetted, and I believe Boston Children's is the home
Yeah.
institution for courageous parents.
There is a new tool on Courageous Parents Network as of about a year ago called Neuro Journey. Which, have you used that before? Yeah, and that's actually a really good tool. Not specific to Batten disease, but really related to all sorts of neurological illnesses, and that walks through common challenges, obstacles that you might deal with along the journey, and then some decision making points and how to navigate all of that.
And I think it's a wonderful resource, especially if you're finding yourself in a situation where you feel like you don't have the local um, care team that you would like to have, and that you're kind of having to figure out some things on your own. It's basically advice compiled from parents over many years, into one online resource. So there might be some helpful things there for you.
If it's okay, I'm going to add a couple other thoughts. My name's Lindsay. I also do palliative care and complex care. And while waiting for the centers to get that network. One of the other ways that your pediatrician could help is going through the listserv through the American Academy of Pediatrics. I know people frequently email out needing help with palliative care if they don't have a pediatric palliative care provider. And I've reached out to people across the country too if there's something that's new that I haven't seen. So that's one resource. And if your pediatrician is open, there's also modules within Courageous Parents Network for providers that help give you those primary care, palliative care skills of how to walk through some of these conversations. So just know that there's options, and we're currently working on a guide for the adult providers, knowing that there's just not enough of the pediatric providers around.
I was actually just going to add, sorry. So, it's not on the Android version. It's better on a big screen then. Yeah. Um, I was actually just going to add add a comment to Lindsay's comment there that although there might be the barriers from an interstate physician being licensed to work with a family interstate, is there any barriers to peer-to-peer support from if it was your clinician that phoned the Centre of Excellence and just had a conversation? What does that look like? And
We
is
would
that
welcome
web going to
that.
help?
So we welcome that.
Yeah.
And that is okay.
And we can give out your details because as of
I
tomorrow,
think somebody
the
just
Centre
gave
of
me the card for
yeah, but the Centre of Excellence, the network will be on our website from tomorrow, and you'll be able to click on that, find all of the details. All of the Centres of Excellence have given, I feel like a salesperson, has given their details and direct contact details for the clinic and the directors. So you're able to refer your own physician onto that site to say, well, here's some experts in the field that are willing and have expressly put their hand up to say they'll be happy to offer peer-to-peer support to other clinicians too.
Yeah, I found it online, like oh yeah.
The last thing I would say is if you make it to a center of excellence, I know that that's not always easy. It's quite a trip, even to us that may be the closest. Um, yeah, but if you make that trip, then it doesn't mean that we can't have phone calls with you also in between. Not being able to do telehealth across state lines means we can't bill for it. That's on us, but whatever. But we can give you advice. We can connect with you. We can connect with your physicians. So once we've established that care, we have a treating relationship with you, and that makes it easier for us to continue to support you across distances, despite state barriers. We can still do that.
Any other questions? Comments? Comments from the panel? We've still got about 20 minutes, so
I don't know if it would help. We wanted to make sure there was plenty of time for your questions. But if we've run through all of those questions, I don't know if it would help to maybe talk through a few just like common scenarios, like kind of examples of things that might be happening in a child's life that, palliative care can help with. If I'm seeing a couple of nods, yes. So, thinking back to children who we've taken care of recently, um, I can think of some examples that are not anywhere close to the end of life, but that are really palliative decisions made, you know, just during the course of the illness and during the course of the childhood. Um, Earlier, it was mentioned about surgical decisions, right? G tube, no G tube. If G tube, yes, then when? When's the right time? Okay, we have G tube. But now swallowing control is getting a little questionable. We have the G tube. We could use it for everything, but still, this is a kiddo who loves cupcakes, really loves milkshakes. Like, do we take those away if the swallow study looks bad? So that might be like a scenario that talking talking through the pros and the cons, should we do a swallowing study, like the X-ray version of a swallowing study to get data? If we do it, are we bound by its results? So let's say the child's aspirating on all consistencies and there's really no perfectly safe thickness that they could swallow. Do you then make eating forbidden? I would say that that's a great example of a discussion that's very much values based. There's not a right answer at the end of that swallow study. The right answer is the one that feels right for that child and their family. And the job of the physician in that discussion, I think, is to facilitate the gathering of the data, if that's what the family would value and would use to help them make a decision, and then to talk through the what ifs a bit. So what if we feed milkshake and we aspirate it? Like what could happen? Well, maybe pneumonia could happen, but maybe it wouldn't ever. And um, maybe if it does, we can change our approach, right? Like, so if we're hospitalized and there's a nasty bad lung infection, maybe from that point on, we take it a little more cautiously and no more milkshakes. But you know what I mean? Like, it doesn't, the results of those studies that we may decide to get together don't necessarily have to govern how we behave thereafter. Um, I think, you know, when I think about the way that I practice as a primary care physician, I think that there's a ton of overlap to what a palliative med doc would do. But again, it can be a really nice partnership to collaborate with a palliative med doc. Thinking more close to the end of life. Oh, yes.
Just to That's a really good example, a really good common scenario that we see often. And what is happening behind the scenes is you have all the different specialists sharing their expert opinions. Good thing we have experts to take care of our kids because we need those. But you are the expert in your child, and you know what's best for your child and what really matches with the goals for your child and for your family. So in that scenario, you're hearing things like the pulmonologist reading the x-ray and saying, "Oh, absolutely, this kid can never feed by mouth ever again." Or you're seeing the surgeon saying, "Oh, we need to do the surgery. We need to put in a G tube now." Um, but you're not, all of those are experts in their specialty, and that that's good. We need that. But what really needs to happen is we need to take a step back and see the big picture. Where ultimately, where are we going with this care, and what is really affecting quality of life? What's affecting the bigger picture for this child and for the whole family? Um, that also adds a ton of stress to parents and and caretakers when you're hearing different experts saying you need to do this, this is the right decision, this is what you need to do for your child, but it might not be the right decision for you or for your child. So I understand that, and I want you to know that that is a common experience that a lot of parents share, and it's stressful. So that's another reason to lean on your medical home and your palliative care team. Did you have oh, okay.
Just to make sure everybody's like heard this label, but it's a really important concept. I think that we can give a name to. It's called shared decision making, right? And that's an approach to making decisions, important decisions about which medicines to prescribe or to take, which surgeries to do, which therapies to pursue, whether or not to travel for research visits and things like that. There are pros and cons on both sides of each of those, all of those decisions. And because there's such ambivalence to what would be right and best, the right way to arrive at a decision is via a shared process between the family and their provider team giving them advice. And so maybe if we think back to old fashioned doctoring, like, I don't know, 50 years ago, 70 years ago, I think the notion was that you go to the doctor tells you what's wrong and tells you what to do about it. And you should listen to your doctor, right? And that's maybe a little old fashioned these days. Nowadays, I feel like the right approach to making decisions, particularly in this realm that we are all in of chronic condition management, it really should feel like you're in a process of shared decision making with your care team. And if you're not, maybe advocate for that, because self-advocacy here is really important too. And I just wanted to maybe give one other example, since we have a couple more minutes, of how that transition of a palliative care team might shift in its focus as we do near the end of life. This is really hard to talk about, but I think really important to share about, well, how does that go? So when children have complex and chronic conditions, every day is hard, right? A lot of times I feel as though families that I'm working with are providing an ICU's level of care on a day in, day out basis in their home. And it can be really hard to spot when some new acute illness or some new acute situation is adding in on top of a situation that was already very complicated and required a high level of medical assistance day in, day out. Um, but this does happen, right? Sometimes we just sort of the frame shifts and we move from a rather stable but high level of care baseline to an even more intensely ill model. Very often the child does come into the hospital for evaluations to figure out what's going on. And sometimes what we figure out is that this is going to be a new set point. We may not recover from this level of illness. This could get really hard. And your medical team are never going to be able to predict the future with perfect accuracy, but when we feel like, no, this really could be, that point where we're within sort of a year or half a year of death being very likely, that's typically the point at which that team will shift from calling itself a palliative care team to more of a hospice approach. I would say at that point, the support level provided to families just intensifies, just gets to be even more support in your home, where hopefully care is more comfortably received than spending nights in the hospital. As Dr. Brown said, there's still the ability to treat any intercurrent illnesses. We can still treat the pneumonia, we can still treat the UTI, we could still do the surgery, but that prediction of death being maybe sooner rather than later at that point does allow us to shift into a hospice mode, which allows a more intense level of support in the home, which I think is a good thing. Um, it can make it easier to build a team that then allows maybe discharge from the hospital, from the ICU, say, to get to home. Um, and um, Suffice it to say that's going to look different for every family and every child. But it there is a team there to lean on. I'd say at any children's hospital, there are resources available to sort of make a smooth transition back to home or transition to end of life plan. Um, it's also possible to then revert back to palliative care 6 months later when things level out. This totally happens all the time. Like I said, the medical team cannot predict with perfect accuracy how children are going to respond. Sometimes they do get back to their better baseline, their better prior baseline. And we all recognize it and we say, you know what, we don't need that hospice level of support right now. We're kind of smooth sailing again, have been for this last 6 months. Let's switch back. And that's okay. Right. So it's allowed to kind of do that back and forth. In most scenarios, I think it's generally with the same agency that just sort of has two operating modes, palliative or hospice, but with the same team, the same company sort of in the home. Um, yeah. I don't know. Say anything or add to that or have other examples.
I was just going to add that I think as parents, especially Batten parents, we just get so it's completely consuming. Like you're talking about, like the ICU level of care that we have at home, and it just happens slowly sometimes. It's oh, we're going to add this medicine, or okay, well, now she's going to have a feeding tube. Oh, well, now she's on oxygen. And all of a sudden you look back and you're like, how did this happen? How does, I look at my daughter's room and I look at all the medical equipment in there and you're like, when did that happen? And the wheelchairs and the transfer and the incontinence, all these things. And we're consumed by it. And so I think having someone who knows us from this, from the start with our children, and then also being able to look at that bigger picture and have those conversations with us, because sometimes we know it, but we don't even make the time for it. We're so consumed by just getting through the day. So it really is, kind of having that familiar team who's willing to have those hard conversations with you when they know the time is right to have them. And I mentioned Amelia and RSV, and um we had those conversations really quickly, with her because I was prepared for Batten. I was prepared for the Batten trajectory. I wasn't prepared for RSV out of nowhere and that, for her to change her quality of life. And luckily, she survived. Was she ever the same? And she actually has come back some, but it's different. And then you go home all of a sudden from that hospital and it's a different life then, and so it's then, palliative of, okay, what is our new assessment of, what is her quality of life and how do we provide that. But yeah, I just want to recognize that, all of the parents in here, that we need that team sometimes to help us because we just can't even look up and see it in the moments when we need it.
And some of the things Karen has said during this talk really remind me that when we talk about quality of life, I keep saying it's quality of life for our patients and for their families, but there's a true burden of caregiving. And a lot of these decisions, really, it is important to factor in those care needs and the impact it has on the family. And I know most of our caregivers are only thinking about their child and want the best for their child. And I want to remind you that it's okay to also think about what impacts you and your family and what makes your quality of life easier. And the care plan should reflect that as well.
Other questions? Sounds like they're wrapping up next door already. Final thoughts or words of advice from the panel, each of you. Karen, something you said really resonated with me was early engagement with the service meant that the team got to know the girls at baseline as they were. And so that was always, yeah, something that they go back to. They know who
Yeah.
they are before Batten, and what their interests are and what their personalities are like. And yeah.
Exactly. And I think especially with Batten, we all know they're kind of still stuck on those focuses. So it's easy to remember the things that they still love because we're still there. It's still the same thing. But yes, it's I just having someone who sees you where you're at and remembers the child. That to me, I always say, we know our kids are trapped in there. They're still there. They still know everything. They just can't say it. They can't do it anymore, but they're still in there. So having that familiarity of even their voice sometimes, or just the comfort of that and saying the things that they know that your child has always loved, is just it's comforting. It really is. When there's nothing really that can comfort us through this, there's not. It sucks. Um, but just that little, it's not little by any means, but it just is so helpful, and it makes it makes a hard journey that much easier. So
Just a final offer, if anybody's finding themselves in a place in the country where it's not easy for you to identify what palliative resources you could have, please reach out. I'm Kourtney Santucci through the conference app. You can send me an email, and just happy to help you troubleshoot that. Just use the app. Save a tree.
A lot of times people are scared that every time they come to see palliative care, we're gonna
Wait, for the recording.
it's going to have to be hard and difficult conversations, and that's not always it. We want to celebrate the highs with you. We want to laugh. We want to, see all the good times and walk through the bad times as well. So not every visit has to be these heavy, horrible conversations. It really is a relationship that builds over time. Yeah. No. Mm.
All right, well, thank you once again. Join me in thanking the speakers, and for your time and your heart as much as your clever brains too. Thank you.